from UT Health San Antonio Cancer Center. He will talk about the emerging treatments for MPNs. Dr. Mesa, please.
Hello. Well, first let me give you my thanks to the organizers and to Pharma Center for a gracious and hospitable meeting. Indeed, this is a meeting that I look forward to, a wonderful time for us all to connect and really reflect on progress in myeloproliferative neoplasms. So I hope to build on the great discussion that's been occurring thus far this morning with a discussion of the emerging therapies in MPNs. These are my disclosures. So we're going to focus on many aspects, and one will complement a bit of the discussion that has already been had. But as we try to set out our treatment goals, how do we determine those? How do we determine the burden of having a myeloproliferative neoplasm? And how does that help us identify the gaps we're trying to identify with new therapies? So first, there is the issue of prognosis. Indeed, there has been many publications in prognosis. We've discussed some of them as it's related to PV already. These are just some of the scores that have been generated for myelofibrosis. Now, prognosis is not a surrogate for burden or how much a patient suffers with the disease. Prognosis fundamentally is survival. How long does an individual live with a particular disease? Now, in myelofibrosis, these continue to evolve. This is one of the most recent variants. They continue to evolve quickly, but this one is handy in that there is an applicable website and that no one can really memorize these scores. They change way too quickly, but having a repository where one can enter in the clinical data is helpful. I try to share with our trainees that the purpose of these scores is one, an estimation of survival, realizing that it is helpful on a population basis, but may not be accurate for one single individual. And second, what are the biological features that the score tells us about the behavior of the disease? These in myelofibrosis tell us that prediction of the future certainly revolves around the impact on the blood counts, clinical features such as constitutional symptoms and fibrosis. It also includes the impact of molecular findings. And again, this continues to evolve over time. Now, our group has been very interested in complementing purely the issue of survival with the issue of disease burden. And I raise that because there are patients with PV and ET that may live many years with their disease. They may live the rest of their normal lifespan. But even in that longer survival, they can have significant burden of disease that decreases their quality of life, impacts their functionality, impacts their employment, ability to concentrate, and many other difficulties that may not manifest as fatal complications, but relevant complications. So as I think about burden for these patients, there's the risk of vascular events. In the past, we probably only focused on vascular events, in part because they were easy to objectify. Second, there is the impact of cytopenias, both at baseline but in response to therapy. There is the issue of splenomegaly, and as has been discussed today, I view this primarily as a burden for patients with myelofibrosis, or if present in PV, probably is indicative of patients that are progressing towards myelofibrosis. There is the impact of symptoms. They can be present in any one of the three diseases. They can be multifactorial, and frequently phlebotomy or hydroxyurea is not sufficient for treating these symptoms. There clearly is the burden of progression, and of course none of these things occur in a vacuum. The baseline health of the patient is incredibly important. The patient that is 70 with PV that has had myocardial infarctions and has significant cardiovascular risk is very different than the 40-year-old who is in exceptional fitness. Now, our group has worked to develop patient-reported outcome forms to quantify the subjective nature of MPN symptoms. Many in the audience have helped to participate in developing these tools that now have been tested and translated into a range of languages, and we have identified many similarities, irrespective of culture and geography, regarding the prevalence and severity of MPN symptoms. Now, as we see, the issue with symptoms with MPNs evolve over time, and they do tell us a story. Indeed, if one thinks about the earlier time of disease where we have baseline disease, there can be inflammation, there can be risk of vascular events, there can be baseline difficulty with symptoms. Perhaps with cytoreduction, perhaps that's interferon, perhaps that's something else, we can see improvement in many of these. They may relate to improvements in headaches, difficulties with concentration, or migraines with aura. Many things that are symptomatic of high counts, but don't necessarily reach the threshold of being thrombosis. As I described for patients, thrombosis is the extreme state where there is complete cessation in vascular flow in a vascular bed. There are many things that precede that are symptomatic. Now, there are times that individuals are on phlebotomy alone. If they have iron deficiency through phlebotomy, if they have toxicities from medications, they too can lead to an increase in symptoms. Over time, therapies up or down, all of the impact we have on the disease are relevant. And indeed, over time, we can see that some of these symptoms evolve and can be indicative of more advanced disease. Now, as we look at these symptoms in terms of how likely they are to happen, not all symptoms are made the same. Meaning some symptoms are more common than others. Some might be more indicative of specific issues such as progression or vascular risk. Fatigue is very common across all MPN types, and that's for a range of reasons. There can be difficulties with insomnia. That is probably a surrogate marker of quality of life. Difficulties with mood, difficulties with concentration, particularly with high counts. As I have patients with PV or AT who are physicians who have come to see me, the impact that they state on their ability to concentrate is very real, particularly if their counts are inadequately controlled. There can be early satiety, particularly with massive splenomegaly. This again is more of a myelofibrosis type symptom. Inactivity, issues with sexual dysfunction, not necessarily impotence, but a range of difficulties patients can experience, including decrease in sexual desire. There are impact of night sweats, dizziness, abdominal discomfort, bone pain, headache, abdominal pain, cough, weight loss. Now, weight loss in particular, I think, is a helpful surrogate marker of progression toward myelofibrosis. Indeed, that is one of these features biologically that usually is just not the case in a standard society of individuals that have adequate resources. People do not lose weight without trying, and when they do, it's a sign of imbalanced health and in MPNs, in particular, movement toward myelofibrosis. And by far the most rare is documented fevers. And this in particular, I think, is a real warning sign of progressive disease. Now, individuals have asked, are these symptoms really worse in MPNs than the general population? And the answer is yes. There have been studies conducted with general population controls done in the United Kingdom, which clearly demonstrated differences on the left between MPN patients versus controls. Now, are they similar across different geographies? On the right, you have a superimposition of symptom profiles between US patients and UK patients, and seeing a tremendous amount of similarity in these symptoms. Now, the symptoms are heterogeneous, meaning that they are not limited solely to the subtype of disease. Indeed, I think of them really more in quartiles. ET, PV, MF patients individually might be heavily symptomatic or asymptomatic. What you see here in this heat map data is the increasing symptomatology across the entire population with MPNs. Now, we discussed earlier in Dr. Silver's discussion and Dr. Kalajan's discussion regarding goals of therapy. And indeed, we must have multiple goals. Clearly, we do not wish patients to have thrombotic events. But in addition, slowing or delaying progression of the disease is an important goal both in the minds of patients as well as physicians. So what are our goals? And I think it's very important for us to be mindful of our goals as well as have this discussion with our patients when we are treating them. Are we trying to avoid thrombosis and bleeding? Are we trying to improve symptoms? Are we trying to increase their activity, decrease splenomegaly, improve anemia, improve low platelets? That might be more relevant in myelofibrosis. Is it trying to decrease progression in the patient with PV that has some features of progression already? Is it trying to prevent progression altogether? We haven't necessarily achieved that, but perhaps that is a goal. Is it living longer? Now, we speak a little bit about treatment guidelines, and this is a photo just showing guidelines are no more perfect than the individuals who gather around the table to make these guidelines. Now, guidelines help to set the guardrails of how we treat a patient. Meaning, what are the acceptable options in that situation? Is it hydroxyurea or interferon? Is it pupilbromin? What are the options potentially at a certain phase or stage of disease? If I was to throw out a completely different drug without evidence, let's say Herceptin, or something we use for breast cancer, that would not be acceptable. That's not within the guardrails of our options. Now, what physicians prescribe within the guidelines is really the art of medicine. How do we take all of those considerations or options to come up with an individualized treatment plan? Indeed, MPN patients have a dynamic course. Early in the course of their disease, it is about controlling their high counts. They have symptoms throughout, but they evolve. There are risks of progression, but particularly linked with longer time with disease, as well as even the risk of vascular events. Now, as we think about managing ET in 2019, we diagnose, we assess disease burden, we develop our treatment plan. We have our frontline therapy, perhaps it is hydroxyurea. We have concerns that they have progression toward MF. Second line therapy, should that be interferon? Should be interferon be the frontline therapy in ET or in a subset of ET patients? Is there progression toward AML? Now, we have many gaps in our treatment knowledge in ET. What is the optimal frontline therapy for ET? And later on, my colleague Dr. Yakub will share some of the data from our MPN research studies looking at that issue of interferon versus hydrea with in individuals with ET as frontline. How do we prevent disease progression? And what is the role of JAK inhibition in ET? In PV, you've heard a similar discussion today. What should that frontline therapy be? Clearly much discussion in this audience regarding the use of interferon. Is that in all patients? Is that a subset? Is that only in patients without splenomegaly? Do the patients with splenomegaly still benefit? Where does hydroxyurea fit in this setting? Is there anyone that should receive ruxolitinib as frontline therapy? There's a question of progression to MF. What is second line therapy? And what does progression to AML look like? Now again, our gaps are what is that optimal frontline therapy? How do we prevent disease progression? How early should we consider JAK inhibition? It's remarkable in the US, I can state that amongst academicians, the use of interferon in PV has grown very significantly with the work of Dr. Silver and many others to highlight those benefits. However, in common practice, it is probably not used very frequently early on in the course of treatment. And that has many historical undertows in why that is the case. Many of the physicians in the U.S. have a very remote history with the use of interferon that is biased by negative experiences with high-dose interferon in CML or in other diseases. And trying to modernize their experience with interferon is part of our gap. Now, for patients with myelofibrosis, again, a similar discussion, but with an important alternative path. First, the issue of stem cell transplantation. Is that something that should be considered soon or delayed? Frontline medical therapy, which at this point is primarily ruxolitinib, depending upon a variety of situations. If they have progressed, do they move to salvage transplant, second-line therapy, or do they move toward acute leukemia? Now in MF there are gaps. What is ruxolitinib failure and what should be the approach? How do we treat MF beyond JAK inhibitors and allotransplant? How early do we consider JAK inhibition? So what about the JAK inhibitors? Well, ruxolitinib has been the sole approved agent in myelofibrosis now for many years. And with that, there's a range of reasons shown on this slide why we might consider a patient to have a suboptimal response or having failed ruxolitinib. Indeed, Dr. Vrostovchik and his group have demonstrated individuals after ruxolitinib have a poor survival, in particular if they've had clonal evolution. Now, people have asked the question, well, how do we help to overcome that? Based on the work of Ross Levine's lab, it had been suggested that a ruxolitinib treatment holiday may help to resensitize patients to the benefits of that medication, and this study by the Cleveland Clinic suggested that at least in some individuals that had some benefit. There are multiple JAK inhibitors which continue to be in development, currently now in various stages of advanced phase 3 testing. Pacritinib, fedratinib, and momelotinib, which we'll show you in just a moment here. Pacritinib had ability to improve splenomegaly and symptoms, even in individuals with marked thrombocytopenia. There were safety concerns in the phase 3 study that now have been addressed with dose reductions and a further ongoing study. There was momelotinib that in a randomized upfront phase 3 trial compared to ruxolitinib demonstrated non-inferiority for improvement in splenomegaly, so it was just as good for controlling splenomegaly. It was a little better for controlling, or it was less effective for controlling the symptoms. And it needed to hit that endpoint to be evaluable for the third point, which was improvement in cytopenias. Now the data seemed to favor momelotinib for improvement in cytopenias, but it was not evaluable because it did not reach that symptom threshold. Fedratinib is the third drug, and in the Jakarta study had demonstrated superiority to placebo. There was a second-line study, the Jakarta 2 study, which showed good activity in individuals that had failed ruxolitinib. Now, this agent had gone on a clinical hold because of concerns of the development of Wernicke's encephalopathy. It was in limbo for many years, but now has been picked up again by Celgene that is trying to move the drug forward. The issue of Wernicke's has been reviewed, and the rate of neurologic events is quite low. Whether there's an increased risk of Wernicke's is a subject of a further safety study ongoing. Now, what are the emerging goals then and treatments? First, there are the issue of combinations. This just showing some of the clinical trials ongoing now. As you can see, a very robust pipeline of additional trials of JAK inhibitors, combinations, new drugs in single agent or alone or in combination. Let me highlight just a couple of these for you. First, there's been multiple different trials. This one led by our co-speaker, Dr. Yacoub, and also with colleagues from MD Anderson, of a PI3 kinase inhibitor in combination with ruxolitinib. There have been other PI3 kinase inhibitor and ruxolitinib trials ongoing. multiple thoughts as to why these might be complementary approaches in the JAK-STAT pathway. This trial demonstrated improvements in splenomegaly, as well as improvements in symptoms with the combination, and they were well tolerated. That study is continuing to be ongoing, and like many of these combination studies, part of the challenge is deciphering how much better is the impact of the combination over the use of the JAK inhibitor alone. What is the threshold for then moving these combinations to a randomized study of ruxolitinib alone versus the combination? There are many implications as it relates to two novel agents, the potential two expensive agents together. We clearly are moving in that direction, but it's very complicated moving from the positive phase 2 study to the significant investment of both time, effort, and patience into large phase 3 studies. This combination study is very relevant in that thalidomide and prednisone has been a helpful therapy for many years in myelofibrosis. My group and my colleagues at Mayo Clinic had worked with this drug in a variety of different studies. This study by Rashid Rampal showed improvements in splenomegaly and symptoms, and again, that might be in part from the ruxolitinib contribution. They did also see some improvements in transfusion dependence and in anemia, and that had not historically been the case with ruxolitinib, so it was thought that an improvement in platelets being from the thalidomide and prednisone. Indeed, that combination, they showed both safety and at least preliminary data suggesting improvements in cytopenias. Now, are they sufficiently improved to merit it being recommended on a large scale, or the expense or the potential neuropathy of thalidomide? Probably not sufficient numbers to really answer that question. There are the novel pathway inhibitors. This, again, the study of imetelstat presented at ASH by John Mascarenhas, co-led by Dr. Kilajan. This telomerase inhibitor, previously in a single institution study, had very positive data for myelofibrosis. They presented data at this year's ASH, again looking at 2 different dosing schedules of this agent, and looking at improvements in splenomegaly and symptoms. And with this, they were able to see that there was activity. The durability of treatment response for patients was fairly limited, as you saw the individuals with the stars being ongoing in terms of the therapy. These were improvements in symptoms. So overall, they had seen activity with the imetelstat. Again, these studies, I think, they were favorable, but less favorable than the initial studies had been presented. This is a unique mechanism of action. Whether this agent will be moved forward by the company, I think, is still in limbo. There is the blast phase of disease. This is a huge gap for MPN patients. Progression toward acute leukemia above 10% blasts is associated with poor survival. We now have multiple new therapies that might be beneficial that are available. Venetoclax with hypomethylating agents for patients with high-risk acute leukemia. IDH1 or IDH2 inhibitors for MPN blast phase patients that have those mutations. All of these are potential considerations that have expanded our options beyond what we used to have for individuals with MPN blast phase. Indeed, as I think about these patients, if we are able to induce them to eventually take them to a transplant, that clearly is our goal. However, if not, we will try to see, do we have either a clinical trial or a targeted mutation that we can match from the current therapy. If neither of these are available, we will certainly consider a hypomethylating agent with ruxolitinib potentially as our preferred option. Frequently, the patient is already on ruxolitinib. Dr. Rosavchuk's group has done studies, and there have been others as well, looking at rux with either decitabine or azacitidine. All of those studies have shown that both drugs can be given together. There's no comparative data of azacitidine versus decitabine for these patients. What about non-pharmacologic options? This is an area of interest for my group, perhaps for patients with more chronic disease. But if you have individuals that are on, let's say, optimal medical management, their counts are well controlled, but still they don't feel 100%. They have residual fatigue, symptoms, other difficulties. What else can they do to feel better? With collaborators, we've looked at a range of things ranging from yoga, physical activity, nutrition, diet, and cognitive therapies. We've presented that patients have a great interest in these sorts of complementary approaches. We have done the first randomized yoga studies conducted in MPNs, actually the first ones really in heme malignancies overall, and shown the impact of an online yoga module to improve anxiety, depression, sleep, and fatigue, as well as in a second randomized study, the ability to improve inflammatory markers such as TNF-alpha. We have worked with cognitive interventions to try to overcome the difficulty of distress and mood disorders that can be active in these patients, as well as a meditation-based app called Calm, which has been helpful for improving emotional distress, sleep, and inflammatory markers. My colleague Robin Sherber, who works with me in San Antonio, has had a great interest in nutrition interventions to try to decrease inflammation. It has a variety of nutritional interventions ongoing in collaboration with Dr. Rostovchik's group and our colleagues at MD Anderson. And finally, working with the colleagues at University of California, Irvine, there are information regarding the supplement N-acetylcysteine as a naturopathic anti-inflammatory drug that appears promising in MPN murine models. So what about the future? Well, the future, I think, will expand even to a greater degree. Indeed, as Dr. Silver had brought up the issue of broader cancer therapies, and we need only look at our solid tumor counterparts to see the direction of further activity. What about immune-based therapies? Clearly, there's already efforts looking at vaccines or other type of approaches for calreticulin mutated patients where that is expressed on the cell surface. What about cellular-based therapies? They certainly have been leading the way in lymphoid neoplasms. There are many complexities with myeloid neoplasms. What about checkpoint inhibition? Largely, the single-agent studies of checkpoint inhibitors have not been successful. However, that may evolve or be beneficial with other combination type approaches. What about gene editing? Again, not ready for prime time, being looked at in other diseases ahead of time, certainly has been helpful as a laboratory-based test. What else might be coming in the future? Again, many things, an exciting time, a very robust future, I think, as we develop a deeper and more individualized pipeline for MPN patients. That I'd like to thank our Quality of Life Study Group. These are just some of the members from a consortium of institutions that are working together on these efforts for MPN patients. Thank you.
Thank you, Dr. Mesa.